we can do lab work between $3.50 to $19.50 for a full panel. That same panel, we had a member who was like, absolutely not, I don't want to pay the $19.50. Like, I want to run it through my insurance. Because you could take your LabCorp request bill and process it that way. And we said, we can't take it back. So once you send it to insurance, there's no taking this back, right? $800. How in the world do we get from 1950 to 800?
Is it time to get government out of healthcare altogether? You know, cash for care? Let's find out about that. But first, like and subscribe our channel. Click that little bell icon for notifications. And please find the Devil's Advocate podcast of this very show on your favorite listening app. So, Travis Bockenstedt, you're in the private world of private healthcare. How does it feel to be a greedy bastard making money out of people's misery?
I think there's this huge misconception that if someone's going cash pay and someone's not accepting insurance, that it's evil. But at the same time, the American consumer absolutely hates big insurance. But I think what we need to do is start thinking about, and this is the best analogy to use, would you use insurance to get an oil change on your car? Would you use your car insurance to buy some new tires? No, you would take that responsibility to maintain your car. And what we're really trying to do is bring family medicine back to what it used to be. And the only way to do that is to change the payment model of how primary care physicians are paid.
All right, so let's back it up to a 30,000-foot level. Used to be you go to the doctor, and afterwards he'd send you a bill.
Yep.
And if you had a lot of bills, you would take your bills and bring it to the insurance company, and hopefully they would reimburse you.
Yeah.
That has completely changed now. Most of what a doctor does in his doctor's office is chase insurance money.
Absolutely.
You know, and I don't think even doctors understand how much of their practice, how much of their business is chasing insurance.
Yeah.
I was surprised when I learned that there's something like 10 or 15,000 different codes.
69,000.
69,000.
Different codes.
Insurance codes.
Yes.
And now, back in the day when they had paper, they had this piece of paper that the doctor would circle different numbers.
Yep.
And that would be what they would charge you for. Well, there was a lab test here, and they looked in your ear there, and there was this and there. And each one had a code. That goes to the insurance then comes here, and then he's got to argue with the insurance. And a guy I knew, a doctor who went to Cash for Care, said when he went to Cash for Care, he was able to cut his costs, his prices to the customers by half.
Absolutely.
Is that possible?
It is, and I think what's important to understand that if a practice chooses to accept insurance, 40% of their revenue goes to billing you. That is like the most broken business model ever. Like selling a cheeseburger and paying a team to go get the money back after the transaction. So that's one of the problems. We just talked about the insane medical billing and coding. I think people don't understand what their healthcare record actually is. It's a billing document at the end of the day. It is a way
How do you mean that?
So basically, everything in a fee-for-service practice, fee-for-service that is taking insurance, if you come in and say, I have a cough, right? It's bothering me. And doc goes through your cough, and then you go, but can you look at my knee in the same visit? And they're like, John, nope, stop. And you just go back to the front desk. I need to schedule you a new visit because this can't fit in the billing document structure that we have, which is complete insanity. So when we go cash pay, free market, direct to consumer, we cut all of that madness out because we no longer need it to have revenue to run our practice. Instead, what we've built in a lot of direct pay, direct care practices are a simple reoccurring revenue model. Think of gym membership, YouTube TV, your food box that you get. And that is what completely funds the practice.
So what you do is you charge a monthly fee or something like that.
Yep.
And if I want to see a doctor, how often can I see a doctor?
Same day, next day, unlimited visits. You get after hours care. You can contact your family doctor. Because now We don't have all these barriers to entry into the system. So just direct to your doctor like 40, 50 years ago. No barriers there.
I remember, young man, when doctors would even come to your house.
Yeah.
I remember when doctors would write things in notes in their files. Now you see a doctor, your primary care doctor. It might be a good person, but they don't talk to you. They don't even really look at you. They look at a screen somewhere and they're typing while they're asking you questions.
Yes.
It always seems to be, and it's not a very personal thing. They put things into a computer. The computer spits back the diagnosis or the recommendation. Well, it looks like you, because you're allergic to this, you should probably have this.
Yep.
And it's like, couldn't we have done this at home? Well, no, we don't prescribe anything unless we see the patient.
Right.
And it all becomes very bureaucratic.
Yeah.
Instead of calling up the doctor and saying, I'm not feeling well, can you give me an antibiotic? And him asking a few questions on the phone and then doing it. So cash for care is basically, I pay you and there's no insurance.
None. There's no insurance middleman here in the transaction whatsoever because we simply don't need it. And what this whole medical billing, coding, all this is doing is it's creating moral injury with primary care physicians. Who in the world would want to have 20 to 30 Zoom meetings a day? That'd kill me. But think of a primary care physician, 20 to 30 encounters in a day. They are bringing all that homework with them because if they don't document it, they don't get the codes right, that practice is not making money. And there's a lot of gross incentives in there. Why?
Are you saying that doctors end up spending a lot of time when they're not looking at a patient, sitting at a desk filling out forms?
Away from their family, staying late, because if they do not complete that documentation, there's no way they're going to get paid.
Which is why more and more practices are being gobbled up by hospitals or larger companies, because then a lot of that backroom stuff, hopefully the bigger companies. So the idea of a small practice doesn't really exist anymore. It's harder to do that. I don't know many happy doctors anymore. I mean, I know some specialists, but the GPs, the general practitioners, none of them seem like they're really living the dream.
No, and we are one of 20% of family practices left in the country that are locally owned and operated by the physicians, not big healthcare. So this model essentially makes family medicine more attractive. Think about a family doctor. It's not glamorous. Coughs, hemorrhoids, anxiety, it's the stuff that's not that glamorous, right?
And you've got brain surgery.
I know, right? But you're gonna have some of the same medical debt as your peers. And would you rather deal with hemorrhoids all day, or would you rather be anesthesiologist, heart, brain doctor, $500 million a year? That's the sweet stuff, right? But we have a 15,000 person shortage of primary care physicians. 15,000.
That nationwide?
Nationwide. So
we've got lots of specialists. Nobody wants to do the rank and file general practice stuff.
Right, because family medicine, when done right, should be the foundation of our healthcare system. So many people are ending up in the ER and urgent care because they call their primary and they're like, John, I'll see you in 8 weeks. And you're like, well, screw that. I'm not well now. So now the consumer ends up in the ER and urgent care, and this has many downstream impacts.
Oh, that has happened to me many times where it's like, I think I got the flu.
Yeah.
Or I need a strep test or something. And you call and you go, well, we can't get you in. You really need to go to urgent care. Or it's like, I don't want to go see urgent care. You're my doctor. Just
someone who knows it.
Let me walk in and shove the thing down my throat and tell me what I need. Let me poke holes in what you're selling.
Yeah.
All right. So Pinnacle, give me the full name of the operation.
Pinnacle Advanced Primary Care.
Pinnacle Advanced Primary Care.
You got it.
Worst name ever.
It's a mouthful. Nobody gets it right.
Yeah, nobody gets, and everybody thinks you're the workers' comp operation here in Colorado. So how many calls a day do you get going, why won't you pay my workers' comp claim?
Oh, I get a few a year, and one guy wouldn't even let me breathe into the conversation for 5 minutes. And I said, are you done? He goes, yep. I said, you called the wrong person. So it happens, yes.
All right. The idea of your Pinnacle is I pay you a monthly thing and I get to see a doctor. I get to have a primary care physician basically on call. It's kind of like your own private suite. It's like having a doctor that's there for you.
Yep.
That sounds great. But I'm still paying insurance because, yeah, you might be a great primary care physician. You might be able to do great work on testing my blood and doing this. And, as you said, hemorrhoids and flu and cough and all the other glaring stuff. But if something goes wrong, if I need, if I got cancer, if I've got to have back surgery, I still need insurance for those specialists, don't I?
Absolutely. So
I'm paying twice for healthcare.
a lot of people say, why double pay?
Yeah.
That's one of the things that come up, right? So I think it's really important for people to understand the function of insurance at the end of the day. The insurance system is just a really warped payment model for moving cash around and paying for claims and things like that. A lot of people say, well, get my health care through my insurance company. I don't know the last time United slapped on an exam glove and showed up in your room, right? So what we're essentially trying to say here is you have an opportunity to invest in good primary care, and we will absolutely keep you within the walls of Pinnacle as much as we can. We will bring you cash pay options such as imaging, physical therapy, a bunch of different sort of menu of cash pay that you have available to you.
When you say cash pay, you mean you're going to need a test. It's outside of what you paid for in your subscription.
Yeah.
But we're going to point you to a place that does x-rays very inexpensively. Because just like a doctor, when we did a study once on mammograms, cash for care for mammograms. And we called all these places saying, what do you charge? Like, I don't know. It depends on your
all this stuff.
And it turned out that it was between like $800 to $200.
Yeah.
And so, when you're shopping around for your maintenance care, you can save 75% just by going and shopping around.
Let's use an example of many Americans who have a high deductible health plan. A lot of those folks, depending on how high the deductible and out-of-pockets are, we consider them functionally insured. So you have insurance, but you can't afford to use it until you get hit by the bus, right? So up until that point, you can't. So when you pair that DPC membership with your high deductible health plan, 70% of Americans last year never met their deductible. So they're paying high-cost inflated rates. So a few examples.
Right here.
Exactly, yeah. We can do lab work between $3.50 to $19.50 for a full panel. That same panel, we had a member who was like, absolutely not, I don't want to pay the $19.50. Like, I want to run it through my insurance. Because you could take your LabCorp request bill and process it that way. And we said, we can't take it back. So once you send it to insurance, there's no taking this back, right? $800. How in the world do we get from 1950 to 800? These are like fake markets that are being created. There's no sensibility to it. So now you can see how that high deductible health plan has more power behind it because you can use the cash.
But if I don't have a high deductible plan,
yeah,
then am I paying twice? So I'm paying your cost plus I'm paying for my insurance, and if I've got $1,000 deductible, I'm gonna hit that.
Yeah.
That's a piece of cake. We call it insurance.
Yeah.
It's not insurance. It's prepaid health care.
Yes.
The difference is I want to hit my maximum deductible, and then everything else is free. I've got an incentive, to go to the doctor.
Yeah.
I want that money coming back. It is the only insurance I have that I want to be paid out on. I don't want my home policy to pay. I don't want my life insurance to pay. I don't want my car policy to pay because it means something bad has happened and I'm losing money. And American healthcare has completely perverted what health insurance is.
It is. We have to keep in mind that we are paying into a risk pool, and that risk must be offset to keep costs low. You're either paying into the ACA, you're either paying into your employer's health plan.
ACA being Obamacare.
Obamacare, yep. You're either paying into those risk pools. If we were to say, hey, if we took some responsibility, over our basic health care, and we were paying cash, and those claims were not consistently hitting the risk pool, like $800 draining the risk pool versus $1950. So I will tell you there's two groups of people. There's folks like me, philosophically will not play with the system. I have not had traditional health insurance for 5 years. I choose a health share that pairs really well with the DPC.
Health share. You're using terms, DPC.
Yeah.
Try it again.
DPC, for those watching, acronym for direct primary care.
Like Pinnacle.
Like Pinnacle. Makes our
And-
name even more confusing, right?
Right.
Yeah.
Like your company.
Like our company.
Okay.
Yep. So then what you're getting at is like the stuff outside that we can't do in the primary care. There's another path a lot of Americans are now taking with a health share. A health share, sort of like insurance, it is membership based, and you are all paying into a pool for that. Now, they can discriminate against certain pre-existing conditions because it's not regulated under the ACA or Obamacare. So for instance, if you had knee surgery 2 months ago and you were still going through rehab and all that good stuff and you joined the health share tomorrow, they're gonna say, well, John, this happened prior to getting in, so that may not be covered. But get into the health share healthy and something happens, then they're able to share in those expenses.
Where do people shop around for a health share? Because there are some religious organizations
Yes.
that do it, and then there's some non-religious organizations that do it, and it's a whole different thing, and it's confusing to me because instead of writing a check to the company, some of these are arranged that you write a check to the guy who needs the money.
Yeah,
that gets really confusing to me.
Very confusing. So we don't participate with health shares that choose to do it that way. It's free market, and if they want to run their business that way, great. There's people who like that. I think it's very weird writing a check to a stranger and mailing it to them.
Unless it's me.
Unless it's you might just bill me, I'll send you something. But we work with Zion Health Share out of Utah. There's other folks like Sedera that kind of do the same thing. They function administratively like an insurance company in a sense that you're not having to front a $20,000 bill and wait 2 months for reimbursement while you do that. Most Americans barely have $1,000 in their bank account for emergencies, let alone 20. So Zion, they're non-religious affiliated. You don't have to sign some faith agreement that if you're not married or have a child out of wedlock.
Let's see if I got this. You guys are Pinnacle, but you're not the workers' comp. You work with a share company called Zion, which sure sounds like Zionists, but they're non-religious. Has anyone told you that you guys suck at marketing?
Hey, as a marketing guy, yes.
Yeah.
And that's part of the problem, John, is we don't have a common language. We know the language of traditional healthcare. Everybody knows that. But when I say DPC, health share, it's like I've grown like a unicorn thing out of my head. They're like, Travis, you're crazy. So that's the other problem too, is we don't have an apples to apples. We don't have a common language, which I think hurts the movement from probably going forward as quick as I would like it to.
Travis Bockenstedt runs a company that gives direct health care for cash. Let's get into the cost of this.
Yes.
So I've talked to some of the doctors at your operation. It sounds remarkable that the idea that I can see a doctor as little or as much as I want, and it's not going to cost me any more, that they actually know who I am, that if I call them up, they might be able to prescribe me drugs without having me to come in and do the usual stuff. How much is this going to set me back?
So DPC memberships here in the state,
DPC.
direct primary care memberships.
There you go. All right.
Yep, here in the state, for an individual membership run between $50 and $100 per month. I want the viewers to understand that this is different than concierge medicine. Concierge is where a physician takes a few high wealth families, charges them between $10,000 and $20,000 a year, and that's what they do. Direct primary care is a scalable model, and what we're finding is that this applies to retail, small businesses, and even large employers. So since we last met, we are now in the large employer game. Our largest client is 1,200 lives with a public school down in Colorado Springs.
Wow.
And we
All
are...
right, so let me just, again, language.
Yeah.
A concierge service is I pay a hunk of money, and I got a doctor who is like on me whenever I need doc, and he's like, yes, sir, here we are. What's the difference between that and the subscription service, my term?
Yeah.
That you're saying I can still see the doctor as much as I want. I don't have to wait in lines. I want to see you today. You'll get me in.
Yep.
What's the difference between a concierge and something that I can pay $50 or $100 for a month with you?
I think it more goes back to the free market and what does that consumer want. If you want like you would have a attorney on retainer for you that you're having an issue tomorrow that you can call them, right? I would say that's sort of the concierge piece of it. Those of us in DPC want to economize the model at scale because that's how we believe we can start to change the system. So we need to be able to take this model and scale it for everyday people.
Still, I'm not getting it. What's the difference between the two? So Martian comes down, looks at this guy, looks at you guys. You know, these guys are charging 10 grand a year. You're charging, $600 to $1,200. You should get all the money and all the business because these guys don't have as many clients.
I think, for someone who might, or a family that might sign up for concierge, it's like, hey, this doctor's only taking 200 patients. They're charging a buttload of money, so they only have to take that many. And that's really all they're going to serve. So, the difference, I would say, is what the consumer is wanting at the end of the day. I wouldn't say there's a huge difference between the two, but it goes back to this marketing problem that we have.
So how many patients does your doctor have? If a concierge has 200, how many does a doctor with you have?
We cap at 700.
And what about a regular GP that's, how many patients do they have?
2,500 to 3,500.
Excuse me?
Yeah. And that's the argument they're making out there is like, how is DPC fixing the system, right? There's no way a family physician can meet 2,500 to 3,500 patients a day. Again, they're...
A year.
A year, a year, yeah. They're stacking that panel. They know that throughout the year they have to crank through as many of those patients as they can, but a 7.5-minute encounter with somebody ends up with this. I need to send you to a specialist. And it's just like, really?
Right. Here's why most men, especially, I'll be on my deathbed before I go to a doctor. Why? Because it's a pain in the ass. Yeah. That I go to the doctor, you know what they're going to do? They're going to send me to another doctor, which means I got to fill out a whole bunch of other forms, and I got to wait in line, and I got to find an appointment that works, and then I'm going to go there, and then they're going to bring me back 3 weeks later to do the same thing, and it's like, no, I'll just take my chances, and if I die, I die.
Yeah.
But it's such a impersonal, painful, fill out these forms thing. I don't want to do it, and I need to do it.
Yeah.
I've had a heart attack. I need to go see doctors. And so the idea of having a doctor, so if I did it individually, it would cost me, you said $50 to $100?
Our rates here at Pinnacle, it's $95 for a retail customer to sign up, $195 for the whole family. And then of course there's like the, couples rate and single parent rate and all that stuff. So that's the retail rates. Now businesses, since we last talked, I think last time we were here, maybe we had 50 businesses. We're over 200 small businesses that we work with currently. And because they're buying that in bulk for many employees, we drop it down to $79 a month for a business membership and $185 for a family.
That's remarkably cheap.
Yeah.
What am I missing? Because my little consumer flare goes up.
Yeah.
Everything is a subscription model. You can't even do software anymore. You can't buy it. You have to do it $5. Oh, but you ran out of space. Well, it's going to be $10 a month more for that extra cloud space. So what is the extra I'm going to have to pay?
The extras in clinic are just things that are hard cost to us. So our procedures are $15 out the door. If you need stitches, you need something like that, a whopping $15. I tell people, think of it like having a Costco or Sam's Club card. Everything we do in the clinic is passed to you at wholesale with a teeny markup to cover our transaction cost, right? That lab work ranges between $350 and $1,950 a month. And we just...
A month?
$350 to $1,950 if you were to come in and do the lab work, not per month.
That's $3.50, not $350.
Correct.
So it's pretty cheap. You need to we need to run a lab on your blood. It's going to be less than $20.
And we have a menu.
All right.
So just like you know the cost before the transaction even happens, which doesn't happen in traditional healthcare. We just partnered up with a mail order pharmacy program that's cash pay. And now our members, baked into their membership, get 95% of the generic medications on the market shipped to their home for free.
How much?
95% of the generic medications on the market are now available to our members for free, shipped to their home in 90-day supplies.
Is there another cost for that?
So for the business members, no. So any company that signs up, for retail members, it's a $10 add-on per month for the whole household to have that service. So if mom, dad are on medications, kids usually aren't, but if mom and dad, that's $10 total and unlimited prescriptions sent to their home.
The businesses that are buying this and for their employees, does that legally release them from the need to provide health insurance?
So if you're under 50 full-time equivalent employees, benefit eligible employees, you can be way more flexible in your plan. You could offer a health share. You could just do direct primary care if you wanted. Once we go over the 50 mark, there's a minimum essential coverage that must be met according to the Affordable Care Act. So you do have to provide ACA qualified benefits for your team if you're over 50. In the under 50 space, these small businesses really struggle to compete because one, they can't afford to put in like a full-blown insurance plan, and second, some of their employees may not be able to even afford it. So I'm talking auto body shops, landscapers, salons, things like that, who we are their first entry point into benefits often. Now where the magic really happens with this model is when direct primary care is paired with a self-funded health plan. And self-funded health plans are where the employer assumes the responsibilities for the claim. So I'll just use a very easy number, $1 million, right? If we ran a healthy population, avoided all these unnecessary specialty, ER, urgent care visits, all that, because we did great primary care. If we save that company $250,000 in claims, it goes back to the company. If you have a fully insured health plan and have a healthy population, it goes to the insurance carrier. And they'll still give you an increase next year.
Talk to me about Medicare and Medicaid.
Yes.
So I've got a son who's on Medicaid. He has Down syndrome.
Yep.
So he's on my health care plan, but there's a lot of Medicaid and a lot of Can he go and see one of your doctors?
Currently, no.
Why not?
So
You hate people with Down syndrome?
Man, I would love to take folks, but we're one of 2 states in the country, along with Kentucky, that has not modernized Medicaid to recognize direct primary care. So I was on Cap Hill yesterday. We got a bill through committee, which is pretty amazing to get that through, Health and Human Services. And it's a very basic thing that we want. We do not want Medicaid dollars, but we do want a Medicaid patient to have their own liberty and choice to choose a primary care physician that they trust and they want to get their health care from. Currently, imagine this. This happened last week to us. We have a suicidal patient who was committed last week. Been very difficult. We are her quarterback. We are the constant in her life. She could become Medicaid eligible. The moment that happens, she must be discharged. That goes against the Hippocratic oath of the physician to abandon their patient. But that is what current Colorado Medicaid law says, is that we cannot serve those individuals. And so we just want to fix the piece that says, give them the choice. I keep your money, but man, I was just shocked, and maybe I'm naive, with the lobby, the people behind preventing this change.
Oh, it's a threat. It's a threat.
Insane.
Any sort of disruption in healthcare is a threat.
Yes.
And that's why healthcare keeps getting bigger and bigger and larger corporations that can handle the more and more regulations and the more of this, the more of the paperwork. And it pushes out smaller practices. It pushes out anything that's personalized.
Yeah.
What about Medicaid? So you get older
Medicare.
I'm sorry, Medicare.
Yeah,
I'm
Medicare.
Sorry. So
Yes.
Medicare, someone gets older, they're eligible for
Yep.
Medicare. Can they use their Medicare dollars with you?
No. So they have to we have to sign an opt-out waiver that says we are not going to bill Medicare for our services. Now, those patients aren't banned from seeing us. You just can't take those dollars to subsidize your membership, which again, in free market healthcare, we don't want that. But now, if you're Medicare and something needs to happen outside the walls of our practice, we will just refer into the system because that's where your benefits are to pay for those things.
So it's almost the perfect system for Medicare, that if you can't afford the $100 a month, then you get a lot of that personalized service, cheap drugs, a doctor who will see you. And then when you need a hip replacement, and
Yeah.
we will,
Yeah.
it's like, no, we don't do hip replacements. We'll refer the hip replacement out into the cold world of hospitals and
Right.
insurance,
So
and
they have-
Medicare.
Right. So they have the coverage to pay for that. When we look at the Medicaid system, though, going back to that, imagine every single patient of ours who has access, who is not going to the ER and urgent care for their everyday care. That is a huge savings to the taxpayer every single time. But again, when I was on Cap Hill yesterday, this goes back to the common language. I feel like I was speaking a foreign language in front of the committee, and I'm not blaming them, but it was just a reminder like, wow, American citizens are not seeing healthcare outside of insurance right now, and we're trying to fix the wrong thing. And if we keep trying to fix that madness, we're not going to make any gains.
Well, the secret sauce of government is to hide the costs.
Oh,
That's what everything is. And so you're paying for this expensive health care. You're paying for Obamacare, but your insurance premium looks lower. But but the country's going into debt to make it happen, or we're inflating the dollar, making paper money to pay for it. The bill comes due and it's a whole lot more.
Yeah.
And so hiding the costs so that it looks like you're getting a bargain is how you keep the system going. And Obamacare is the king of that. So you have all these healthy people getting what they think are pretty good rates for their insurance. What they're going to get is lousy service and paying for it someplace else. There ain't no free lunch on this.
Absolutely.
Where do you operate? I live in Boulder.
Yeah.
I would like to check out your operation. You don't have one in Boulder, do you?
We don't, but if you Google direct primary care in your area, yesterday I found out we have about 90 of us in the state right now currently doing
90
direct
operations like yours.
Independent direct primary care physicians.
Are
that
there
doing this.
direct primary care physicians, I'm getting the lingo, that instead of doing a subscription model, do a menu model that will say, hey, every time you come in, I'm going to charge you $25?
No, and I think the reason for that, it creates a gross incentive. So the idea of the more we have you come in, the more revenue we'll make, the more we'll put in the piggy bank here. And most of us who run what is a pure direct primary care model, it's really just that reoccurring revenue that pays for those visits. So
I know a doctor out of Seattle, Vern Cherwin-Tanko. I haven't talked to him in, 20 years. But he had a cash for care. And he said, I got to cut my costs in half once I got rid of insurance. And I was able to then charge my patients half.
Yeah.
And it also meant I could let go of all those people who in my office that did nothing but chase insurance payments. And he said, so I came up with like 3 to 5 price codes, real short, medium, long, and real long visit. But he said also, it allowed me to, if a little old lady came in and had no money, but brought in an apple pie, apple pie is fine, because it is illegal in the insurance world to charge somebody differently. But he's cash for care. He can charge you nothing and charge you $1 million, and so he could help people who couldn't afford it. I don't know if you have that leeway here in Colorado.
In terms of how we price ourselves and all of that, there's no hiccups for us. In 2017,
What does that mean, no hiccups?
In terms of how we run our business, I'll go back to 2017. Then Governor Hickenlooper signed DPC, direct primary care friendly legislation, because the Division of Insurance wanted to wrap DPC up under the Division of Insurance. And again,
makes no sense because there's no freaking insurance.
We are not insurance, right? So that was huge. That was big. So we got that done in the state. Big, beautiful bill. Trump and their team put in a updated direct primary care legislation that now you can put your DPC membership on your HSA card and receive those benefits.
Oh.
Just like Medicaid patients were banned from putting their DPC membership on an HSA, which is nuts because you can put a lot of what I would consider not healthcare stuff sometimes on your HSA card, right? But paying for a doctor, an independent doctor, so we got that passed. So we're slowly modernizing it. But I would say, we're this little thing with this big monster over us, and I'm reminded of that sometimes. Capitol yesterday, I was reminded that we've got work to do. We need to evangelize what we're doing and help the consumer understand it more.
How many doctors do you work for you?
So we currently have 5 physicians that work for us. I've got 8 physicians wanting to work for us. And I told you about that 700 patient cap. Once they get around 500, we're out to market to start hiring another physician. Reason being is we don't want to disrupt the model. We want to make sure that we're still getting patients in same day next, still providing that great care. So I've got some physicians who've been 30 years in the industry and are thinking about hanging up their hat because they're burnt out, but we're keeping them for an additional 5 to 10 years. One of our co-owners, Dr. Lynch, she said this model gives me 10 to 15 more years in the biz.
Why?
Because she's not burning out. She
Because she's not doing
hate her
paperwork.
job. Absolutely, right.
She's not doing half of her work filling out papers for insurance.
She gets to be a doctor, what she went to school and signed up for.
It reminds me of teachers. I've heard teachers in private school say the same thing.
Good example.
I've heard teachers say, "Oh, I don't get the benefits that I could in a government school, but I get to teach. I'm not a babysitter. I don't have to follow, all these procedures. I'm not in endless meetings.
Yep.
I actually get to make a course plan and work with my kids, and the joy of that is worth the less money because I've got freedom." So it's like that.
It is, and our physicians working in direct primary care, they don't make much less than their peers in an insurance model. So it's not like they're taking a huge cut in pay or giving up a bunch of stuff to be in this model. But I think it's a win. If these physicians, top-notch, experienced physicians, are staying longer in the system,
let's be honest,
benefits everyone.
all these guys got their medical license from some university in the Caribbean somewhere, right? It's the Grenada School of Medicine.
We just send them to the Caymans for a 1-week program.
Yeah, is that how you save the money?
Yep, and then we just bring them in, and there you go, John. Have fun.
You want to give an answer to that one? No? Your doctors are board certified.
They are
doctors.
Top notch. Yep, and they have the same prescribing privileges as everybody. Referral.
Do you have nurse practitioners?
We do. So we have a model where each of our clinics has an MD or DO assigned for the physician leadership part of it, and then we have NPs and PAs. Mid-levels are awesome. I mean, if you give mid-levels a collaborative environment to work with their peers, it works great. And we're finding young physicians coming out of school going into direct primary care now right away, not being ate up and spit out by the system. We're starting to grab them and bring them straight into family medicine, which I think is pretty cool.
People want to get some more information, want to take a look at either the model or your company specifically. Where are good places for them to go?
So 2 things to do. Number 1, when you're on Google direct primary care.
Direct primary care.
You got it.
Not the Denver Center for Performing Art, but
No.
direct primary care.
Direct primary care, a guarantee here in Colorado, something will pop up. Around the country, there's about 1,500 of us. So someone listening out of state, Google one near me. If you're in South Denver or Colorado Springs, Pinnacle can serve you. Just go to pinnacleapc.com.
Travis, this was great. Thanks.
Thank you. This was
I
awesome.
appreciate it.
Appreciate you.
Think freedom. Did you enjoy that conversation? Well, check out one of these. We have the most interesting conversations with Colorado's most fascinating people. Be sure not to miss a single one. Like, subscribe, hit that little bell icon. And if you can't watch, listen. Check out the Devil's Advocate podcast on your favorite listening app. And by all means, think freedom.